Being a vision scientist, I am concerned. And this paper is more like playing the devil's advocate. What works, what will not work, what can work, how does the future look? Many of you have tried the corneal techniques. That is to say, we have done presbyopia, some kind, with different profiles, like the Reese technique, the Telangna technique. Some of us have even tried monovision and Avalos technique. None of them have really survived, except one, as you will see on the following slides, and that's the Chopin profile. Coming into the first generation of corneal inlays, of course this was the aim to improve near vision performance, creating a central myopic 3mm area, or increasing depth of focus, partially using the Pinot principle. What you needed to have was a lacy cut and an intracorneal inlay placement. And it was said to restore up to about 2 diopters of amplitude of accommodation. And you're all familiar with this slide, the camera inlay. I do have my concerns. No matter how good a femtosecond laser you have, the stroma bed will not be even. What about deposits on the inlay, even if it's very, very thin? You can never perform retinoscopy on an eye with an inlay. Cosmetically, you can actually see the thing. Fundus examination is making, it's a little bit difficult to do it. Should the inlay be placed on the visual axis or the optical axis? And of course, we have a restricted field of view and diminished vision in poor lighting conditions. Along came another femtosecond laser, the so-called intracore, for low to medium additions, mainly directed towards the young presbyopic patient. But these eyes needed to be more or less symmetropic. Cosmetically, you could actually see the fine rings. You had glare and halos in abundance. And it is an irreversible procedure. We will come back to irreversibility later on and also in the discussion this afternoon. So the visual effect, side effects of all the mentioned procedures that you have, Presbyopia, Presbymax, Swim type, text solution, supracore, perfect vision, whatever you like to call them, will actually give reduced visual acuity for distance, and it will also be intolerable for some patients. Reversibility of these procedures has not been shown to date. Therefore, surgeons must take utmost utmost care in patient selection to make sure that the procedure doesn't cause permanent harm. There are two publications I'd like to draw your attention to. One paper by Aliu, reporting on examination correction of presbyopia in 50 eyes of 25 patients, that is to say presbylasic, showed 20% lost 2 lines of distance-corrected visual acuity and 50% lost 2 lines of near-corrected visual acuity. Second publication is by Nortz, reporting on 63 patients who underwent the intrastromal femtosecond laser procedure in the non-dominant eye. 7 eyes lost 2 lines of distance-corrected vision, and 11.5 lost 2 lines of corrected near visual acuity. So almost 20% of patients were not satisfied with the result, and 12% said they would not have the surgery again. These procedures, I repeat, are irreversible. Frank has mentioned a lot of multifocal IOLs. Again, the results are not that good. And why is that? That is due to the following reasons. Imprecision in IOL power calculations, inherent limitations and accuracy of biometry, post-refractive patients' eye hyperopic surprises, and a longitudinal shift of the IOL after implantation. Astigmatism due to surgical wound healing, the pre-existing astigmatism, and IOL rotation in the case of toric IOLs, and finally presbyopia correction. There are some refractive limitations of current IOLs. 1/3 of the patients have a residual spherical refractive error of about 0.75 diopters or more. That's more than a loss of more than 1 line. Another 1/3 have a sphere corrected, but a residual astigmatism of 0.75 or more. Another loss of another line or more. So, in fact, 2 out of 3 IOL patients have imperfect distance vision. The refractive multifocal implants, if we look very closely at these, it's not a perfect solution, since the binocular vision did not provide the best expected results. It was not conceivable to accurately correct the ametropias, such as presbyopia, with these implants because of insufficient near vision. And to guarantee a good visual outcome and in a reproducible manner. The diffractives had a diminished effect observed today with the standard diffractive lenses. Poor intermediate vision, 6-10 maximum. And the results are not always reproducible, since, due to, the optical quality could not be ensured. Should have excessive astigmatism in post-surgery resulting from incision size, and lower contrast perception, that's what we call light symmetrical distribution, and unpleasant nocturnal visual symptoms, halos, scatolite and glare. If we look at the peer-reviewed literature, we see a confirming growing incidence of PCO. And this might be related to small incision IOLs, where the rate is about 4 times higher compared to standard IOLs, and to multifocal IOLs, where the rate is 3 times higher, even when the lens material is the same. PCO might not be a big problem for monofocals, but with multifocal splitting light onto 2 or more foci, that will result in a loss of light intensity. So even with small amounts of PCO, the contrast sensitivity will rapidly decline. What about today? Supracor, a new treatment, is also referred to blended vision, multifocal or bifocal laser, or what have you not, and there are many configurations of this method around the world in different countries. Looking at that profile presented by the Supracor, you can see it's quite similar to the Chopard profile. A little bit improved, but not a lot. What about the mechanical accommodative lenses, like Synchrony? The Aqua lens, that's the one that slides. The new lens. I started to work with new lens 2003. We are now 2013, and as Frank quite rightly said, not a lot have been implanted, and a couple of those implanted, for your information, have been extracted. PCO is in abundance with these lenses. The Aqua lens, you can imagine what happens if the minutest amount of debris comes inside the interface. It will not slide anymore. Synchrony, well, they wasted a lot of money. In fact, a hell of a lot of money. Around, the rumor says, about $400 million. They will never be able to retrieve that. Again, the interface is the big problem. And Liliana Warner already showed this about 3 or 4 years ago. And as soon as there is debris in the interface, it's a goner. So maybe, put on the bottom, they may be obsolete already. Lentis M Plus and Lentis M Plus Toric certainly looks very promising. But again, rumor has it, I have not seen any published papers yet about it. It's too early. But rumor has it that there is quite a build-up of PCO on these lenses. The light adjustable lens, we will hear more about this afternoon, is an expensive method, but it gives you the opportunity to customize your treatment for presbyopia. Because you could have adjustable monovision, you could have customized DRAD, and you could have a lens with asphericity control. What about tomorrow? The raindrop near vision inlay, Mark will talk about that this afternoon again, looks indeed very promising. And we and we will hear some results from him later on. Extremely thin, non-visible corneal implant. Again, if you look at that, the corneal cross-section, what do you have? It's a Chopin profile. Presby smart, and I'm not just saying this because Alan is here. It's an innovative trifocal lens, which certainly looks very, very promising. Some of you guys have already started or are about to start to implant it, and Suri will collect the results, and we will see what it all is about. Why does it look so promising? In simple layman's words, it has got a superb optical quality. And this might be one of the answers or clues to why this lens could be a success. Many of the multifocal IOLs up to now have shown a limitation of intermediate vision. This lens, as well as the lens of fine vision that we will also hear about later on, will most probably give an excellent intermediate vision. And it gives an innovative comfort for the patient. With each of these lenses, you have an optical quality guarantee that nobody else can give you. I want to finish off with pharmacological correction of presbyopia. We've talked about this for about 2 years now. Nothing happened until suddenly a friend of mine from Slovenia popped up and said, I have it. Because the drops from Argentina during these 2 years we have not seen. Now there are 3 people in the audience today that have been dropped a couple of hours ago now, 1.5 hours ago. And I can see that Mark is reading quite nicely. I know that Sherry can look at her watch. I don't know about Johan, how you feel about it. Your reaction was that when it's getting a little bit dim, you know, my vision decreases, my far vision decreases. But how is your near and intermediate vision?
Well, just to report back on the general lighting conditions, it looks a bit darker, a little bit more soft, and then the reading is definitely better, and my distance vision is normal. So it's working.
It is working. I cannot measure my reading vision. I would say it's about J4 or 5 at the moment.
Well,
which is a lot better than the J10 that I usually have.
That's great.
So it does work to a certain extent.
And how about Sherry behind you?
My distance vision is quite improved. My depth of field is much better. I can see the slide. I mean, I could always see the slides, but I was putting my glasses on, and I actually see better without glasses for distance, and I can also see better at intermediate. And this is dim lighting, but I can actually read some of the light grading of letters in this one brochure. So certain things I can see pretty well. I bet if I had good contrast letters, I could see. I mean, it's not perfect, but in this lighting, but it's a definite improvement, and I can read the numbers on my watch where I couldn't before. And it took about 20 minutes for the feeling to go away, and then it was gone. So that's what I don't feel it in my eyes.
That's our experience as well. So this was a totally unscientific, very amateurish, if you like, way of trying it out on 3 patients, and they all seem to be fairly happy. So, John.
Klaus, that was a mistake. If you did 2 patients, you would automatically have a straight arm. Why confuse the issue?
I always like to have challenges, you know.
Especially a woman.
So, thank you so much for listening, and I do hope I've given you some food for thought. Thank you.